The government has identified the National Hospital Insurance Fund as a key driver of universal health services. The fund has undergone major transformation in the last 10 years to align it to this plan. What is the role of NHIF in the UHC plan? Joining us this week on Inside Government to help us understand this plus more is the Chief Executive Officer of NHIF, Dr. Peter Kamunyo. Thank you very much indeed for finding time to be with us on Inside Government.
Thank you very much, Obran. It's indeed a pleasure for me to be here on your show.
I mean, when you look at NHIF and the reforms that have been undertaken in the last 10 years, which one would you say had the biggest impact on the fund?
In terms of the reforms for NHIF, I would not only pick the last 10 years because it has been an evolution from the time NHIF was formed as a department under Ministry of Health way back in 1965 and actually 1966. And since then, it has been progressively reforming to meet the needs of the people of this country as well as to make it sustainable to continue doing that. And in terms of some of the major milestones, I think the first one was like in 1972 when voluntary membership was allowed, and that created the platform that we can now start riding on to get to universal health coverage. Way back then, NHIF, I think it was known ni bima ya kitanda ya hospitali, because we were only paying bed for hospital beds, basically. And from 2015, there was that other major change, whereby now we started paying for outpatient as well as packages, like oncology package for cancer, surgical packages, packages for rehabilitation, and very key dialysis. And this has now happened within the last 10 years, within the tenure of His Excellency the President.
A lot of arguments, has been passed across that, the real transformation of NHIF happened in 2015. And now it is about to move to the next phase of major transformation following the passing of the NHIF Amendment Act in December last year by Parliament. Do you agree with this?
I totally agree with it. From 2015, it was a major milestone because now we could provide wholesome coverage to ensure that nobody goes out of pocket while accessing medical services. And the current reforms are actually now major to take us to the next level, which is the next level is ensuring that we get to a state of universal health coverage by changing NHIF to become a strategic purchaser of healthcare services. And in the current reforms, which have been informed by very many task forces and key and driven a lot by the Ministry of Health, I would put them in 4 big buckets. And these 4 big buckets, number 1 is digitization. And in digitization, if you're going to cover the whole country, whereby everyone is paying a premium and we are paying claims, it is not possible to engage at that level on an analog fashion, on paperwork. So digitization. And we have embarked on that process in a big way. If you recall, in 2020, October 31st, His Excellency the President launched our biometric registration, which currently is the way that you're able to access services. So we are doing away with the cards. When you go to hospital, you don't have to wait for your principal member to bring the card to access services. Just your fingers and you're able to access. We've also, since July of last year, July 11th, we've launched our electronic claims. Now the hospitals are submitting their claims electronically.
So this is what we call, this is where now staff rationalization comes into play.
Exactly.
Are you likely to lay off some of your workers?
We are likely to align our staff appropriately.
Meaning?
Meaning, for example, if it is digitization, we make sure that the staff are retooled, reskilled to ensure that they're able to do that. Staff who might opt to be able to go if for example, their jobs are no longer required, that might happen. But the process is currently ongoing. We actually have a team that has been working on it, and we shall have the final structure with the final establishment to show us and take us to the next level of NHIF.
Are you likely to embark on a VEF, voluntary early retirement for your staff?
I think that would be advised once we are complete with the process, because looking at the staff as we are ensuring we have the proper assignments to be able to deliver on the promise and to deliver on the journey to UHC, to be a strategic purchaser. So that is something that will be explored, and it will not be the first time that we have actually done that in our reform journey.
Let's talk about, your staff, because any organization is as good as its workers.
Absolutely.
When you look at, staff workload analysis,
Yes.
What information do you get?
NHIF is actually a social health insurer. So we are literally an insurance company. So all the functions that you find in an insurance company, you also find with us. And as we increase the sophistication and employ more technology, we adapt. And I'll give you an example. Like our customer experience center. By May 2020, we were only able to do about 200 calls a day. Right now, we are doing about 6,000 calls a day.
And when you look at, the core competencies of NHIF, the work demand and the phase that now you are entering, vis-a-vis the core competencies of your staff, what do you get?
One of the things, we have really evolved. If you look at our operations now compared to 10, 15 years ago. And the beauty of this organization as well is that it also invests in training of its staff. And that has been an ongoing process. So you'd find quite a number of the members or the staff who are there now have undergone various trainings. And these trainings have been also in conjunction with the ministry, also supported by our development partners, in order to upskill in the evolution. And even as we are looking towards the organizational transformation, and that is where even employing more staff who are competent in certain areas that skill is currently not within the fund is something that we are looking at. And that is something that will push.
When you look at, customer service satisfaction level, yes. for NHIF, yes. It ranks the lowest in the insurance industry here in Kenya at below 50%. In the new phase and in the organizational transformation that we are embarking on, how do you plan to boost this?
Customer satisfaction, in fact, in insurance of any form, is almost the core of the functionality of it. And why do I say that? Because insurance is a business of trust. You give me a small premium and then I promise you this level of business. And for any member to access that benefit, they are in a loss situation. You are actually unwell. So how you interact with the member when they need that service is very key, because health is emotive. Very, very key. Now, as people compare, it would be good to also understand the scale of NHIF. On average per month, we handle about 150,000 admissions and close to 400 to 600,000 outpatient visits. I'm sure when you compare with the private insurers, you'd find it's a very little fraction of that.
Of course, it is expected, bearing in mind that NHIF controls almost 80% of Kenya's insurance premiums.
Actually, not. Actually, not. In the last year, the premiums collected in private insurance was actually about 44 to 45 billion. Yet the premiums that NHIF collected on the National Health Scheme was only 38 billion. 38 billion covering 23.5 million lives, and 45 billion for about close to 2 million lives. So you can see the difference is actually quite huge, yet the benefits are almost similar.
Private insurers have always argued that it is high time that the National Hospital Insurance Fund is divided into two entities, one to offer social insurance, and the other one to offer commercial services in a bid to level the playing field. Do you agree with them?
NHIF is a social health insurer, and NHIF operates not for profit. And when you look at even what is proposed in the new NHIF Act amendment, the operations of NHIF will be twofold. The National Health Scheme, where we have the membership of the statutory contributors who are the formal sector, the informal sector, and it has been proposed that they will be obligated to pay, and sponsored programs for those indigent and vulnerable population who would be sponsored by government, counties, and other well-wishers.
Do you believe, the current business model of NHIF is sustainable?
Absolutely. Absolutely. And there have been certain tweaks or reforms to ensure that. The current ongoing reforms are specifically geared to ensure that we transform into a strategic purchaser of health, to ensure that the benefits cover the growing needs of Kenyans, and to ensure that sustainability. And that would be achieved as a social insurer by having the whole pot. The biggest challenge that we've been having that has been threatening the sustainability was, for example, the voluntary part of contributions. In fact, I can tell you, like in the last financial year, for every shilling under that group, we spent 3 shillings in terms of claims. And why? Because it's voluntary. So because people don't understand the concept of insurance, whereby you pay when you are well, so that when you're unwell, it takes care of you, only the sick, only the ones who have need, only the ones who need surgery, only the ones who need dialysis, only the ones who need to deliver were actually paying. So now with the new law, and that is why it was very important that the NHIF Act amendment, the regulatory framework to support that leap into UHC and to support the sustainability of this vehicle, NHIF, to ensure that we achieve one of the big 4 agenda of His Excellency the President.
You see, the original design of NHIF, was modeled along the NHS, of England. But when you look at, the amendments that were passed by Parliament the other day, you see a lot of similarities between the Obamacare, social health program and NHIF. But critics have argued that whereas the Obamacare caters for a certain group of Americans who cannot afford health insurance, on the other side, NHIF requires serious reorganizational skills in a bid to get to where it ought to be. Do you agree with this?
NHIF is already on that path and has been on that path. Over the years, as at the last end of last financial year, the number of members registered was about 12.9 million principal members registered. So that means if you translate that into the number of individuals, that time we're looking at about 23.5 million, which is close to 50% of the Kenyan population. So those are already people who have been in the system and enjoying services. So in terms of capacity, it is there. But also we recognize that when we scale up, that the capacity needs to increase, it needs to change. We need to also adapt to the growing needs and technology. And that's where the reforms come in as we are adapting. The other thing is in terms of getting to universal health coverage, there are different models. And the model that we have adopted now is what we call output financing model, or an insurance model, whereby we transfer the risk from the payer to the insurer.
Let's look at the bill that was passed by Parliament the other day that is awaiting presidential assent. There was a lot of complaints from especially employers who argued that, if the bill was passed, it was likely to make, number one, the cost of doing business here in Kenya high, and number two, it was also likely to lead to a spike in operational cost of companies. And so, no wonder that clause was struck off by Parliament. What would be the implication of that clause in the new NHIF?
There's a wise person who said once, health is wealth. And a healthy nation is a wealthy nation. So primary drive towards ensuring that Kenyans and employees have good health is very important. Now, in terms of like in the Act, there was the issue of employer matching contribution. I would like to draw your attention to, even privately insured employees or Kenyans is less than 2%, it's about 2%. And for the employees, the contributions we get from employees as we speak now ranges from 150 shillings to the 1,700 shillings per month at the top band. You'd be surprised that 13% of all those contributors actually contribute less than what the voluntary contributors contribute, less than the 500. Meaning that 13% contribute less than what, the person out there who does not know whether they're going to earn a shilling that day or not. So that was one area that needed some correction. And when you look at any country that has been able to achieve universal health coverage, their employer also puts their skin in the game. So right now, as it is not the employer who is contributing, it is only the employee through that deduction.
This matchup by employers, was part of your future revenue projection. Now it is not going to come. How would this impact your operations?
I think it is when you look at the bill as it had passed the National Assembly on the 21st of December, is that there will be employer matching for those who do not have their own private insurance, or their private insurance is of lesser benefit.
But the number is negligible.
It is negligible in terms of, and I actually would not say negligible, because every contribution actually counts. Because we are looking at the bigger picture. Every contribution actually counts.
The other issue that came out, when that bill was being discussed was, your operations cost, your operational cost. And it was argued that, at about 14% of your total revenue, that was considered to be very high. And the reason why this was is 14% is because there are a lot of wastages, and the duplication of roles, within the organization. Do you agree with them? And if it is true, how would you bring this down?
One of the key areas of reforms is to continuously contain the administrative costs. In fact, it would be good for you to know that, like in 2017, for example, the administrative cost was at, I think, about 22%. In the last financial year that we've just gone through, the admin costs was at 11%. So this is continuously going down due to increased efficiency, also, and as you mentioned, reduction of wastage. And as we increase the pool, that is bound to go down even further. Our target is actually to get the admin cost at about 5% when we have a state of UHC. And that is a journey that we are committed to. That is a journey that you can see from the numbers progressing for the last couple of years, we are continuously pursuing.
The other issue was, political patronage. And, save for the last 2 or 3 years, I mean, there was a time when NHIF was synonymous with boardroom wars and political wrangling, which somehow impacted negatively the trust of contributors. How are you going to ensure, going forward, how are you going to ensure that, NHIF is shielded from political patronage and boardroom wrangles?
Yeah, that's a very heavy question. But one of the things is, you can see we have a very committed board right now, led by our chairman. And all these efforts, all these results that we are seeing, we could not have seen without the board working together.
But boards come and go.
Boards come and go. And we are looking at the periods. Number two, the support that has been continuously coming from the Ministry of Health to also support, because the Ministry of Health is our oversight. Number three, if you look at even the proposal in the NHIF Act amendment to further improve on the board composition so that we are able to discharge on this. There is the inclusion of Council of Governors. There is also the inclusion of ensuring that the skill mix within it is able to support the functions of the board.
Let's also look at the issue of fraud within the health system in Kenya. And, it is as high as 35%, 40%?
It is high. It varies. The statistics, and we don't have the full statistics, but it's anywhere from globally from 10 to about 30%. Yeah, many studies in different countries have shown, varying. And indeed, it is a global problem.
The attempt to try and suppress that number, through legislation, was thwarted by members of parliament when they shot down, the proposal to make it more punitive for fraud claims. How will this impact on your attempt to cut the number of fraud claims in your system?
In terms of managing fraud, there are many ways of managing fraud, because fraud also is perpetuated from different levels. Fraud can be member-driven. More often than not, the member themselves are in the middle of it. It can be driven internally by support from staff. And the other key player in terms of that is the provider. So all this interplay. And the types of fraud, the most common one that we have is like impersonation. That O'Brien, I take your card and I go and get services. We actually almost look alike. So I could pass for you. Now, and that is one of the biggest causes of fraud. So how do we reduce that? The reduction of that is what we've done by introduction of biometrics. The other one is claims and fictitious claims by providers. They actually manufacture claims. I can give you horror stories of people we've caught who have rooms full of people just manufacturing claims. So now with the e-claims, that should reduce that.
What about internal fraud?
Yes, also internal fraud. We have a policy, and anyone who is caught, and we do have cases currently in court because of fraud. So the minute we catch fraud, what we say is justice delayed, justice denied as well, but is quick to action to ensure that there's prosecution, and that will help to reduce as we move along. And our policies are internal policies, is corruption-free, and we want to uphold that, but also we know that there are rotten eggs here and there, that action is taken swiftly and promptly.
In the case of reimbursements, how do you plan to rationalize and standardize, your reimbursement? Because it absolutely does not make any business sense, that in one hospital you're paying 50 shillings for Panadol. In the next hospital you're paying 500 shillings for Panadol. How do you plan to rationalize that and standardize?
I particularly like that question because we're in the process of recontracting for our cycle of 2021 to 2024. And that, what you've said, is the key, one of the key new things that we have put on board. And that is complete standardization of our reimbursement across all levels. So all level 2 healthcare providers will be paid a same rate, whether they are public, whether they are private, whether they are faith-based. And we've extended that all the way to level 6s. And we've also looked at the rates to ensure that we adjust them for risk for facilities that deal a lot with non-communicable diseases. So a lot of work that the team and the board has been doing over the last 1 year to ensure that at this point in time, we are able to cure that lack of standardization and standardize our reimbursements across and this also will help in reducing fraud and also reducing the complaints and delays, because now it will be possible to also automate the interaction. Because when you have differential rates, it means you require human intervention. But now when you standardize, we're able to automate even our interactions.
Because we have to come to the end of this interview. Kenya has been talking about achieving UHC by December 2022. We're talking about 10, 11 months from now. Yes. Do you believe this is achievable?
Absolutely, and without a doubt. And to say that, because I always say this even to my team and people who engage, what is universal health coverage? It is not a scheme. Universal health coverage is a state where every Kenyan has access to the care that they need without suffering financial hardship. It doesn't mean it is free. It means, O'Brien, if you can afford a lot more and go to hospital XYZ, you're free to do so. But the person who does not have access is identified and supported so that they can also get that care. And that is demonstrable right now because the government has started by identifying the poor and vulnerable. And this was done through the Ministry of Health and Ministry of the Department of Social Protection. And of the 5.1 million indigent households, the government has already paid up for the first 20%. 1 million households, as we speak today, can be able to access care.
What's your message of assurance to people who are watching this program and asking, is Kamunyo talking about the same NHIF that we have known?
Indeed, we are talking about the NHIF that you have grown up with, that is evolving to make sure that it is there for you continuously. And this is in keeping with the government's agenda, Big Four agenda, to ensure that every Kenyan has access. This is in keeping with the Ministry of Health's efforts to ensure that provide an environment where every Kenyan has access to quality care without suffering financial hardship. So it will need you and I to work together to ensure that we keep our contributions up to date so that NHIF can always stand by you throughout to ensure the health of our people and to ensure that we actually get into the state of universal health coverage before the end of this year as the government and His Excellency the President Big Four agenda.
Asante sana Peter Kamunyo for joining us on Inside Government.
Thank you very much, O'Brien.
Dr. Peter Kamunyo is the CEO of a National Hospital Insurance Fund, joining us on Inside Government to help us understand what the fund is doing to help in the achievement of universal health coverage here in Kenya. O'Brien Kimani is my name. Thank you for watching. We do this again on Friday next week. Have a good afternoon.